Good morning, everyone, to our friends from the East Coast, the West Coast, and around the world. Welcome to another Fellow Project webinar. We are really excited for today's session. I don't have a lot of housekeeping, and I know this is a packed topic, so we're going to go ahead and just get started. On a side note, it was really nice. I got to meet a lot of you at the meeting in June, and I just wanted to say it was really just awesome to hear from you and get your feedback on the Fellow Project and other ASMBS things. So thanks for that. Thanks for joining us today. And I'll begin by introducing our speakers. So today we're going to be talking about obesity, bariatric surgery, and cancer. Our first speaker is Dr. Ana Pena, who was born in Cuba and traveled to the United States at the age of 18. She completed her undergraduate degree in biomedical engineering at Florida International University and completed medical school at Herbert Wertheim College of Medicine. She finished her general surgery training program at Cleveland Clinic, Florida, and her fellowship training in advanced GI and minimally invasive surgery, foregut and bariatrics at Cleveland Clinic, Florida in July 2021. Dr. Pena is currently an MIS general and bariatric surgeon at Cleveland Clinic, Florida, and was recently appointed instructor community-based faculty at Florida International University's Herbert Wertheim College of Medicine, as well as clinical instructor of general surgery at Ross University School of Medicine. She loves to play volleyball, but also enjoys racquetball and table tennis. And nowadays, her favorite pastimes are her children. Thank you, Dr. Pena, for joining us. She will be followed by a man who really needs no introduction at all. Dr. Rosenthal has been a leading force in bariatric surgery for a very long time, and we are delighted to have him. He is a professor of surgery at Cleveland Clinic, Florida, also chair of the Department of General Surgery and director of the Bariatric and Metabolic Institute there. He is a past president of ASMBS and editorial chief of SWORD, and really one of the friendliest people you will meet. Dr. Rosenthal, thank you for joining us. We're really excited to hear from both of you about this really important topic. I felt that this was something we haven't covered yet on this webinar and is something that really is up and coming. So please, Dr. Pena, take it away.
Good morning, and thank you very much for giving me the opportunity to be here and for that great introduction. It is a privilege for me to be talking to you all this morning, and it is also a privilege to be presenting together with my mentor and someone whom I admire and respect very much, Dr. Rosenthal. So we will be talking about obesity, bariatric surgery, and cancer. In 2016, the American Society of Metabolic and Bariatric Surgery did a national survey conducted by NORC at the University of Chicago to determine the perception about obesity among Americans. And interestingly, we saw that Americans perceive obesity as a very serious health condition. It actually tied up with cancer as the two top most often cited as serious health conditions, even more than heart disease and diabetes. So 2 years later, there was a publication about some statistics that were very surprising. 640 million affected by obesity in the world, and this was linked to 13 different types of cancer. So we all know that the prevalence of obesity continues to increase. It actually increased from 30 to 41% over an 18-year period. And when we talked about severe obesity, it has also increased. It has increased from 4.7% to 9.2%. And it is estimated that by 2030, 51% of the US population will be considered obese. Obese has also an economic burden. It is estimated that in 2019, the medical cost of obesity was nearly $173 billion. Later, we learned from Obesity in America survey that the prevalence of obesity is highest among African Americans, followed by Hispanics, and then whites. And the risk of overweight and obesity-related cancer increases in older persons, those with age greater than 50 years old, and also is higher among females when compared to males. As the obesity disease continues to expand worldwide, the presence of diabetes mellitus also continues to increase. And if we look here, it is estimated that by 2030, in the Americas, there will be 66.8 million of patients with diabetes mellitus. If we look at Asia and Australia, there will be 190 million patients suffering from diabetes, 48 millions in Europe, 42.6 millions in the Middle East, and 18.2 millions in Africa. And why is this so important and something that we really have to think about? Well, in 2014, Maher taught us that if you have obesity, you have an increased risk of developing an obesity-related cancer, and the risk increases by 50%. However, if you are obese and also have diabetes, the risk of developing an obesity-related cancer increases by 200%. There are 30% of severely obese individuals who have diabetes, and that group is the one as the highest risk of developing obesity-related cancers. In 2017, the CDC published a paper about the incidence of cancer associated with overweight and obesity. It included a 9-year period, included only invasive cancers, and they classified the cancers by the anatomic side and the histology. And what we found was that the risk of developing obesity-related cancer was highest among postmenopausal women, and the three most common cancers were breast, here in yellow, ovary, and endometrium. So these three are hormonal cancers, all associated with postmenopausal women and obesity. There were other cancers that were also found to be at an increased risk when they're in obese patients, such as multiple myeloma, pancreas, colon and rectum, among others, with colon and rectum being the second most common type of cancer with an increased risk in the obesity population. So in conclusion, overweight and obesity-related cancers accounted for 40% of all the cancers diagnosed during that time period, and 55% of the cancers diagnosed in females, as well as 24% of the cancers diagnosed in males were obesity-associated cancers. So now what's going on? What's happening? Well, we clearly don't have a complete understanding of why there is a link between obesity and cancer. Some studies have shown an association with chronic inflammation. There are some theories about insulin resistance, metabolic dysregulation, and steroids. In the case of breast cancer, there are over 67 metabolites that have been associated with increased BMI and risk of breast cancer. People talk about the metabolomics. But what we know is that there has been an association, there has been a study between telomere length and the risk of cancer. And we know that individuals with a short telomere are at an increased risk of developing cancer because short telomeres lead to genomic instability. So what happens? So as we age, the length of the telomere shortens, and we have found that the same thing happens with obesity. So here you see the older the person in the table, in the graph, the shorter the length of the telomeres. And this is what happens with as we age as well, and with obesity. This is another study that showed the association of telomere length and cancer. It was a meta-analysis. There have been multiple reports. This is another report. And now in this case, it studied the changes in the telomere length after bariatric surgery. And this particular study conducted by Rosenthal, it included 50 patients who underwent gastric bypass, and they studied and collected blood samples between 3 and 5 years after surgery. And what they found is that there has been the shortening of the telomeres in obese patients, but they found that after the weight loss from the gastric bypass, it impacts the telomere length. So 30 out of the 50% actually had an elongation of the telomeres after the bariatric surgery, in this case, the gastric bypass. Now, this other study studied the length of the telomeres and how it increases after weight loss. Now, in this case, this was a 10-year prospective study, and it included patients who underwent a gastric band as well as a gastric bypass. But the majority of the patients, 128 out of 142 patients, actually underwent gastric banding. And what the study showed is that with the pronounced and sustained weight loss, there is a relative increased length of the telomeres by 0.024. And what's interesting is that in this case, it didn't matter whether it was a bypass surgery or the gastric band. It seems that just the sustained weight loss is what causes the lengthening of the telomeres. And this is very, very good and very important because it's not, with the bypass, we could argue that it's the changes in the foregut or the hindgut, but when the case of the band, there is no changes, no hormonal changes or physiologic changes. And this is another study that in this case, they check for the exercise-induced weight loss, and it also showed that it may lead to telomere lengthening with the sustained weight loss after exercise or lifestyle changes and nutrition. So in conclusion, all of these studies have shown that whether it is exercise or any type of bariatric surgery, the weight loss is what leads to the lengthening of the telomeres. And as we talked about before, when the telomeres are short, it increases the risk of cancer. So lengthening of the telomeres could decrease the risk of developing these obesity-related cancers. And thank you very much. Now I leave it to Dr. Rosenthal.
So, yeah, as Anna said at the beginning, and Shaina and Kunoor also mentioned, the American Society of Metabolic and Bariatric Surgery is making a big push for people to understand how serious the obesity disease is. And I'm going to highlight that towards the end of my part of the presentation. SWORD is coming out now with a special issue. It is already available to you guys online. With those who participated last year's ASMBS Clinical Congress, Dr. Kotari led that session, and we had really national and international experts that spoke about epidemiology, physiopathology, et cetera, about obesity and cancer. So keep it in mind when you talk to your patients, specifically the postmenopausal women. They don't need to have diabetes, they don't need to have hypertension and sleep apnea with a body mass index of 30 to 35. Just tell them that it's the right decision because the likelihood of developing cancer is increased by 55% if they are postmenopausal. So it's very powerful. And before I get to tell you how bariatric surgery might impact obesity-related cancer, let me tell you that we know very, very clearly how impactful this can be for our patients when it comes to all kind of different procedures. So it is the umbrella of weight loss. It is the umbrella of obesity, but we don't know. Anna strengthened the telomere length, but I can tell you, as you saw before, that it might be diabetes, it might be sugar. It might be the lipids. It could be hypoxia in patients with sleep apnea. We really don't know exactly what happened. This was one of the first presentations that kind of ticked me off and made me gain interest in obesity and cancer. And that was Ted Adams that published in 2007 in New England Journal of Medicine, a very nice study. And what he did is he looked at mortality after gastric bypass. And he compared in his study severely obese subjects that went to get their driver's license. The cohort was a very large cohort. 7,900 patients that had bariatric surgery versus 7,900 patients that did not have bariatric surgery. And what he found out is that if you had bariatric surgery and lost weight, the likelihood of dying was decreased by 40%. But what really ticked me off of this paper is that 60% of these patients died from cancer. That's where my interest in obesity and cancer started. And if you come to IFSO in Napoli, I'm running a session on obesity and cancer as well, because this is very important. This is another very important paper published in the Annals of Surgery by the group of Kaiser Permanente. This is Daniel Chaar, not Phil Chaar. It's also a very famous Chaar. He's a bariatrician, he's a statistician and a great researcher. And he looked at 5 different sites from Kaiser Permanente in a period of time of 10 years. What is very strong about this is the huge patient population, 16 million non-surgical cases versus 33,000 surgical cases. And they matched them, and they were very, very well matched. So it's not only the quantity, but the quality of the data that he came up with. You see that the incidence of diabetes was equal. The incidence of hypertension in both cohorts was equal. The only thing that there was here a disparity at that time when this was published, gastric bypass was still the most, favorite kid on the block. Now it's sleeve gastrectomy. But what he showed, as you can see here, that those who had bariatric surgery had a much, much, much higher cancer-free survival than those who did not. So, and this is with all cancers. So this was a very important message. And then the next thing that it's important, this is a paper that followed the same patient population, the same 5 study sites, same period of time, equally matched. And then he looked at 18,000 surgical cases versus 40,000 non-surgical cases. But instead of looking at the incidence of cancer alone, he said, okay, let's see what happens with weight loss at 1 year. What is the incidence of cancer depending on how much weight these people lose 1 year after they start doing exercise, diet, or 1 year after they got a gastric bypass? And what he showed is that the more weight you lose, the more is the protective effect against cancer. So those who had a weight loss of greater than 30%, that we know very well that only bariatric surgery can get there, probably now you can do exercise, dietary interventions, and one of the new GLP-1 agonists. So what he showed is the most protective effect is when you lose more than 30%. And this is also a take-home message. It's not just about losing some weight and looking good. It is not just about getting your arterial hypertension under control. When it comes to prevention of cancer or obesity-related cancer, in this study, we are seeing that you need to lose at least 30%. A similar study came from the LAPS study, the longitudinal assessment of bariatric surgery cohort. They saw that the cancer risk will drop if you had at least 20% of excess body weight loss. So again, supporting the results that you just seen from Chaar. This is a study coming from a British group from the United Kingdom, published in the British Journal of Surgery. Mackenzie in 2018, hormone-related cancers, colorectal esophageal cancers following bariatric surgery. It was a population-based cohort study that looked also at 15 years, and they matched, gender, age, comorbidities, very similar to the one that I just showed you from Dr. Chaar. And what they found here, this is the control. The control in red are the patients that are obese that don't get bariatric surgery. And the blue dotted line are the ones that get bariatric surgery. So you see that the incidence of cancer or cancer-free survival was much higher in those who had bariatric surgery, specifically the hormone-related ones, than those who did not. In our journal in SWORD, the Executive Council and the Clinical Committee put out also a white paper strengthening the role of bariatric surgery in decreasing the incidence and prevalence of obesity-related cancer. This is a study from the group of Nazario, 2020. The relative risk of breast, ovarian, and endometrial cancer was 0.41% confidence interval, and the risk of breast cancer was reduced by 49%. The risk of ovarian cancer was decreased by 53%, and the risk of endometrial cancer was reduced by 67% if you had rapid weight loss induced by bariatric surgery. I can tell you guys, wake up and smell the coffee. Not only bariatric surgery has a great impact, but obesity is a serious problem. Female-specific cancer, this is also a very, very important paper that was published by the group of Anvenden in Sweden, prospective obese subjects, median follow-up of 18 years, bariatric surgery associated with reduced risk of overall cancer. We presented at ASMBS, and we were lucky to publish in SWORD despite, I think I had to revise this paper 5 times because we use the NIS database a lot. And, you know, the NIS database talks about admissions, and we use admission as a proxy to incidence and prevalence, but we could not conclude necessarily that based on our presentation, we could 100% demonstrate that bariatric surgery decreases the incidence of cancer. But we know the NIS is the largest all-payer inpatient care collection and hospital data in the United States. You have more than 7 million hospital admissions. If you decide to use the NIS database, and I'm talking now to fellows, make sure you read the JAMA paper of 2017 that tells you exactly how to use that database to publish. It is an edited and audited database. You cannot publish what you want. You need to have someone being the gatekeeper. So we look at 5 years, 1.5 million patients that did not have bariatric surgery versus 250,000 patients that had bariatric surgery. And the odds ratio, again, of developing cancer was reduced significantly in those who had bariatric surgery when compared to those who did not have bariatric surgery. We presented at the Clinical Congress of the American College risk factors associated with liver cancer in severely obese subjects and the impact of bariatric surgery. It was also concluded that there was a higher risk of liver cancer in obese diabetic patients, and that bariatric surgery represented a preventive measure, decreasing the number of first-time liver cancer admissions, all based on the NIS database. Risk factors associated with primary colorectal cancer in severe obese subjects, NIS database, similar conclusions. Family history of CRC and personal history of polyps were the most significant risk factors of colorectal cancer, but bariatric surgery showed decreasing the number of first-time admissions for colorectal cancer. This is a paper published by Ali Aminian, Steve Nissen, former chief of cardiology in Cleveland. I'm including this paper because I provided most of the sleeves. We called it the Splendid Trial. It made big waves. It was in CNN and the New York Times. Again, we looked at whether bariatric surgery was associated with a lower cancer risk and mortality, which is a little bit different, similar to the Ted Adams study. We looked at patients with body mass indexes 35 or greater. It was a 13-year period of time. And we looked at patients who had bariatric surgery, about 30,318, and we compared them to those who did not have bariatric surgery. The total cohort of none was 25,000. The cohort of bariatric patients was 5,000. We matched them. And overall, what we found out in conclusion was that bariatric surgery was associated with a decreased incidence and decreased mortality. As you can see here you see the total weight loss with non-surgical management in blue, and you see the weight loss in orange with surgical management. And here you can see the surgical management group in orange had a much higher cancer-free survival than in blue, those who did not have as much weight loss. And this was, as you can see in the right upper corner, similar for the bypass as for the sleeve gastrectomy. Right upper corner, you see my arrow. So Anna mentioned about the banding. I mean, the banding is like tying a belt around your neck. You don't change the physiology. There is no foregut, hindgut, midgut, Uralian cells, you name it. But here we compare sleeve and bypass, and it further strengthens that it is the rapid weight loss, that is the remission of the comorbidity, and potentially all of the above, resulting in telomere instability that then generates cancer. So our conclusions of this study was adults with obesity and bariatric surgery compared with non-surgery were associated with significantly lower incidence of associated cancers and cancer-related mortality. We're going to get to the conclusion because we're going to leave some time here for discussion. And there were similar scenarios. I think this is important for us to understand why it takes time for people to change their minds around a new idea. Between the 16th and 19th centuries, scurvy killed more than 2 million sailors. Now, the most horrifying thing was that for 300 years, medical experts knew very well that to prevent it, how to prevent, but they did nothing about that. In 1600, captains started to distribute lemons and oranges to the sailors. But the British Army stopped that. Why? Because it was too expensive. And this is what we bariatric surgeons and you fellows that are going to go into practice are going to face with your patients. That insurances will put them on a preoperative diet that I'm sure you discussed during these webinars to lose weight, otherwise they don't qualify. And they expect them to be BMIs of 35 to 40. One of my criticisms to the current guidelines that the BMI should be 30 and above. Why? Because of cancer. But the insurances are not going to cover. But see what happens here. They knew it, but they stopped it because of cost. Until in 1747, James Lind did an experiment, did some science, and gave some sailors citrus, and to the others he gave vinegar. Those who took citrus survived because of vitamin C. The other ones all died. And then they started understanding that this was important. Same thing happened with asbestos. First recorded death, 1906. It took us 70 years for us to ban asbestos. Same thing happens with seatbelts. That's what Volvo did, Niels Bohr, in 1959. Took us 9 years to make it mandatory. These are some of my favorite writers, Yuval Harari, and he says that we are entering a new era of intelligent design and adaptation, that we are developing bodies, brains, and minds, and the humans are going to, not like Darwin here, we're going to become cyborgs. Well, the truth of the matter is that we are not becoming cyborgs. Things are getting worse and not better. And I don't know what is intelligent about what I'm showing you here. It's affecting our children, the elderly, the mid-adults. How long did it take the AMA to declare obesity a disease? Founded in 1847. It was recently, 5 years ago, that AMA said, oh, obesity is a disease. So it takes time. And while we wait and wait and wait, the rate of obesity continues to climb. By 2030, we are the world champs. We are the heaviest one on the planet. But by 2030, we're going to be with staggering numbers. Dr. Pena just mentioned you at the beginning. We estimate this is obesity alone. Severe obesity is going to be probably close to 10%. And obesity overall is going to be probably by 51% in the United States of America. But look at here, it's affecting everyone. The Asian Pacific. Final thoughts, I think that more people are dying from old age than disease. More people are dying from suicide and violence. And more people are dying today from obesity than from starvation. And we were all able to overcome famine, plague, wars. There are still conflicts here and there. We all know what's going on in Ukraine. But the numbers are not so staggering as the obesity disease. It's killing nowadays millions and millions worldwide. And it's a pandemic. I can say that in 2022, 2023, sugar is far more dangerous and life-threatening than gunpowder, and that we are our worst enemies. The World Health Organization described, and this is from the year 2000, obesity as one of today's most blatantly visible, yet most neglected public health problems. And I'm asking you all to please pay more attention to obesity and cancer, the impact of the obesity disease on the incidence of cancer and mortality, as I showed you before. And yes, let's keep talking about the hindgut, foregut, midgut theory and about the microbiome. All that is fine. But let's not forget about the obesity disease and cancer, which I think it's so important. And that concludes my presentation, and I'm going to stop sharing my screen. I think we have good time for questions, Kunoor.
We do. Thank you so much for that. We know what the problem is, and we know what the solution is. And we had a fantastic talk last month on access to care and how we can all get involved. What do you recommend to the fellows going out there now? They're going to start their jobs next month or in the month after that. How can they use this data to be impactful and make a difference where they are?
Well, the first thing is, when you look at the new guidelines from ASMBS that state that you are a candidate for bariatric surgery with BMI 30 to 35 with a comorbidity, let me say that those are wrong. I objected as chief editor of SWORD too late. Otherwise, they would have included it. But don't feel like your patient needs to have diabetes, hypertension, and sleep apnea if the body mass index is 30. If you have a 55-year-old postmenopausal woman in front of you with a BMI of 30, and she wants to sleep because she's worried about her obesity, tell her what the CDC told you in 2017, that she has a 55% increased risk of developing breast, ovarian, and endometrial cancer. So this is the first thing you should feel comfortable. And this data helps you, I won't say change your practice, but strengthening your practice and the recommendations you make.
I also, somebody posted, have you heard of any lawsuits or legal action to position the lack of coverage for treatment of obesity as discrimination? Could this be a viable route to forcing coverage?
Oh, guys.
I was going to say that's a little loaded.
I don't want to get political here because we're on a webinar and this is ASMBS. But I think every single day when you turn on the TV and you hear about lawsuits, you see so many people that should be in jail and they're not for committing more serious crimes, discriminating, insulting, infuriating, offending. I haven't heard that anyone really got away with a lawsuit for discrimination yet in America. And I unfortunately live in the state of Florida when it comes to that subject. So yeah, I haven't heard about any lawsuit.
Somebody asked a question about types of cancer where obesity is protective.
I haven't heard about obesity being protective when it comes to cancer. I think we are on the early stages of understanding. I mean, I tell you, 2017 is a 10 years report from CDC. We're talking about 5 years ago, 5 years in the history of humankind. Imagine AMA took 100 years to see that obesity is a disease. How long it's going to take us to convince humanity and people that obesity generates cancer. I'm not sure we're going to see anytime soon what kind of cancers obesity can prevent from happening. I don't see any disease process that obesity can protect against. probably against cold weather. If you don't want to freeze, you have an extra layer. But yeah, I don't see any prevention from obesity disease.
And I was going to say the only protective factor that I can think of that it provides, honestly, is that the amount of weight often that patients lose with chemotherapy and immune modulator treatments, oftentimes they'll.
Well, if I may interject, Kunoor, you're touching on a very important subject here. Dr. Ganem from the Mayo Clinic and some others, including ourselves, we're gathering our data. We have a series, I think, of 11 patients that were diagnosed with cancer and underwent bariatric surgery before having their cancer operation. Carcinoids, hypernephroma, and that was done in conjunction with the blessings of the oncologists and the primary cancer specialist. Patients undergoing chemotherapy lose weight, but the dosage of chemotherapy needed for a severely obese subject is much higher, as you can imagine, than the dosage for someone that is not obese, number one, which impacts healthy organs. Access is a serious problem in the severely obese subject, which is more difficult than in the non-obese subject. And as you can see here, there is so much happening under the obesity umbrella that we yet don't understand. We spoke about metabolomics, we spoke about telomere length, we spoke about diabetes. There is so much good happening for the cancer patient when they have rapid weight loss. I can tell you that we could do a webinar next year, academic year, about heart failure. We are currently doing sleeve gastrectomies on patients with ejection fractions of 10% or less. And we put in Impellas or LVADs to have them survive the operation, because otherwise they don't get their heart transplant. But you know what's funny? That some of them don't even get to heart transplant because there's so much good happening. And guys, the cardiac surgeons, the liver transplant surgeons, they come to me and say, Raul, I can't believe it. The diabetes is gone, the sleep apnea is gone. They don't read our papers. They don't hear our talks. And it's important for us to go to their meetings and to get access to their sessions. We are not selling them sleeves. We are saving lives.
Great point. That actually, you mentioned telomere length, and we've known, I remember in medical school learning about aging and telomere length, and we know that this happens. We know it's a phenomenon. Now we know it's related to probably obesity, but we don't know any mechanisms. It's interesting that we haven't been able to figure this out very well as far as exactly what is happening. Do you have any thoughts on what that mechanism is, or how, what road do we take with that concept when it comes to
mechanism of cancer linked to obesity, or mechanism how bariatric surgery works?
both?
Well, I'm a true believer that something has to do with our genes. I think changes have to be happening at the cellular level. And I don't know if you know that taking insulin and maintaining your blood sugar as a diabetic at normal levels doesn't prolong survival. So what we see and what we measure is not always what's happening at the cellular level. And that is why I believe that getting into the cell, getting into those chromosomes, getting into those genes, measuring those telomeres, I think that's where that really is where the show is happening.
Yeah.
At the cellular level. I think that when we talk about metabolomics, if it's the lipids, if it's the sugar, if these are tumor necrosis factors or any kind of toxic metabolites that are being shed from liposomes, fat cells, brown fat, white fat. I think the research is endless. We got to start somewhere and somehow. I have a protocol now where I'm looking at telomere length because I'm a believer that we need to strengthen that route. Now, someone probably should take a deeper dive and start looking at and measuring some other things. We are measuring hemoglobin A1C, et cetera, et cetera. We're not measuring everything, but from that perspective, I think that that's where the etiology comes between obesity and cancer. As far as bariatric surgery, I think the rapid weight loss, the remission of comorbidities, the remission of the chronic hypoxemia in the sleep apnea patient that creates pulmonary hypertension, glaucoma, and renal failure. You know, talking about metabolites, we just presented at the Clinical Congress for the Halverson Award, and we published extensively, including at Annals of Surgery and presented at ASA. About 30% of obese patients don't know that they have chronic kidney disease. Mm-hmm. They come, we put them through the OR, and we suddenly see, oh, look at that creatinine. It's a little bit higher. A little bit higher creatinine in an obese 30, 40-year-old young adult means chronic kidney disease. With bariatric surgery and rapid weight loss, it goes into remission. It prevents the level 2, level 3 kidney failure patient to go to kidney transplant. Some of them to go into dialysis. So, and with that, you know, improving kidney function, improving the cleansing of our blood, of metabolites, et cetera, probably it's helping too.
Yeah. I think also, if you look at NAFLD, you know, there's regression of disease where we thought we'd never see that regressing. We are. So there is definitely something happening. I think also when we talk about telomere length, it's important to think about epigenetics. So I recently went down a rabbit hole and started reading a lot about the genetics and then the epigenetics of obesity and bariatric surgery. And if you look at the last 2 decades, you know, what's really changed? Why is it worsening? And some of it is, you know, what are we surrounding ourselves with and putting into our bodies that's changing our genetic makeup, that's changing these telomeres? And I think the problem is there's so many different genes to study, and there's so many different epigenetic changes and algorithms that it's Pandora's box, right? You can't really study it all.
Yeah, another important aspect, you mentioned access to care, and there was a question about lawsuits. Dr. Pena showed it's strengthened by the CDC, by the Obesity in America survey, that the 2 largest minorities in this country are probably the most affected with obesity and obesity-related cancer. Our Black community and our Hispanic community, and they have also problems with access to care, as documented in publications in SWORD. And I'm sure you heard that from John Scott and from John Morton and from many other leaders that really are experts in this subject. So this is something that we also need to fight for. There is a disparity in access to care. It probably has to do also with access to healthcare education, economics, et cetera. But, you know, we can look at what are the triggers for that. But it is not right. And we need to, as a society, emphasize, try to educate not only our African American or Black population, our Hispanic population. We need to educate them as much as we can. We should have all these kind of webinars also in Spanish so that they can understand, read. But we also need to go and lobby, you know, we need to go to the Hill. And that's what the, you know, Obesity Action, Obesity Coalition is doing, the OAC.
And last month, Renee Hilton and Joe Northup both did stress that. A reminder to the fellows, one day a year can make a really big difference. So if you can, your local chapter of ASMBS probably has a day on the Hill, or your local chapter of your ACS. Definitely join and get involved and fight for these things for our patients, for people who don't have access to preventative care and therapeutic care. Those are both, I think, equally important in obesity care. Dr. Rosenthal, somebody said you mentioned offering bariatric surgery to BMI 30 plus. Are those patients going through insurance or self-pay? I will say we did recently have a patient, one of the bariatric surgeons in North Carolina submitted a patient with a BMI in the low 30s, less than 35, who is a severe diabetic, and they agreed to cover it. So this is going to be a case-by-case basis, and I think it's going to eat up our time for a little while. But if we spend enough time doing it and we show them data that we are impacting change in this patient population, we're only going to help ourselves and our patients.
Two take-home message. The first one is that it takes time for people to change their minds around a new idea or a new concept. And the second one is that nothing lasts forever. So the second concept should make you hopeful that at some point this is going to get better, but it's going to take time. I've been operating on BMIs 30 to 35 probably for the last 10, 15 years when they are diabetics. And, it takes time. You need to pick up the phone and you need to talk to the medical directors. There is an appeal process. And you need to be part of the appeal process to get that patient to the operating room. But I can tell you the medical directors are the lowest denominator of good science and good medicine. They have a very cruel and strict financial interest. The great majority of them, I don't want to blame everyone, but many of them say, listen, this is what it reads, this is what it is. And for you to tell them what the CDC said in 2017 or what the data is showing, it's not helpful. But there are two aspects here. One is, what is insurance going to say if you have a BMI of 30 with no comorbidities, obvious comorbidities, but you want to tell the patient you have a 55% chance of developing hormonal cancer? That is one. The other one is, you as a surgeon, do you feel comfortable in doing a sleeve gastrectomy? And I say a sleeve gastrectomy, and I didn't say a SATI because you should not be doing one of those operations in a BMI of 30. So do you feel comfortable doing a sleeve gastrectomy on that patient, despite insurance not covering? What if the patient develops a leak? Do you think that if you get sued, you don't have a way of defending yourself? Well, what you heard today is defending yourself in front of any court, because you have data showing how bariatric surgery prevents cancer. You have data showing how BMIs of 30 have a 55% greater incidence of developing cancer, et cetera, et cetera, et cetera. So I think these are the two take-home messages.
Those are really great points. Shaina, good to have you. I got through, I know we had some questions. We talked about telomeres. I didn't know if you had any other questions.
Yeah, I was curious. So, and I don't know if you had a chance to talk about this. I was thinking more endometrial cancer specifically. We have really tried here, based on some of the data that you presented and data on in small series, that weight loss or treatment of obesity actually can help with regression of endometrial cancer. And we've struggled with trying to come up with a way to approach it where could we use bariatric surgery as part of the treatment of cancer? And wanted to see if you've had any experience in how to approach that practically with either endometrial cancer or other types of cancers.
Yeah, we discussed before, Shaina, that we've done it for hypernephroma, single cases, I would say anecdotal cases. I'm not recommending this. I want to make sure that these are all single cases where we're putting together a large case series with Ganem at the Mayo with Omar. We've done it as a stage approach. I think bariatric surgery could be not only a final step, but also a first step when you manage patients with cancer. Final meaning preventive. First step could be to do a sleeve gastrectomy for a patient that is super morbidly obese, diabetic, hypertensive with sleep apnea, and was diagnosed with hypernephroma, and they don't feel comfortable in doing that operation laparoscopically, and of course not open. But what if they need to open the patient because there is a thrombus getting into the IVC, and this cannot be done, laparoscopically safely? And the surgeon says, listen, it would be helpful if this patient loses 100 pounds. In the meantime, we can wait. As we know, with hypernephroma, it's a very slow growing tumor. So that would be a perfect case for a stage approach. And I am not yet current with endometrial cancer evolution as such. Can you wait? How long can you wait? But if you could, you have a much better surgical candidate if you get them to have rapid weight loss and remission of comorbidities.
Yeah.
Shaina, we have several patients. So we tried to start a study at Duke. I collaborated with some of the gyn-onc and medical doctors here, our hem-onc doctors. We didn't get the study up and running just because there wasn't a budget for it. But, I personally have 3 patients who has been cured of endometrial cancer because we did bariatric surgery. The earlier the stage and the earlier the intervention, the better the outcomes. I've been lucky. Most of my patients have a BMI of 40, and so we've been able to just operate pretty rapidly. The issue becomes when it is between 30 and 40 and their comorbidity is cancer. And I think that's where you pick up the phone and you talk to the medical director and you beat them over the head with the data. But I think this really is one thing that we could show really good data on. So I'm hoping somebody is working on a paper out there.
Yeah, we've tried to come up with a protocol focused on atypical hyperplasia as a starting point, or low-grade endometrial cancer with people who want to maintain fertility, meaning they don't want a hysterectomy. And a lot of our issues have been timing, not BMI, but more of do they require medically supervised weight loss? And so we've submitted all of them to insurance without medically supervised weight loss, and I've only been able to overcome like 1 or 2. Unfortunately, I've been much more successful when it's been hepatocellular carcinoma or a neuroendocrine tumor, which I recently did a patient who has an NET who needs a Whipple, and we were able to overcome the medically supervised weight loss so the patient could lose weight to have a safer Whipple. But with endometrial cancer, with these small series that showing regression, it seems like the ideal first step if we could and I'm struggling with the insurance side. The appeals process has just kicked my butt here. It's interesting to hear y'all's perspectives and thoughts as an opportunity, because I know there are some gynecologic oncologists here and around the country that are excited about the opportunity to partner and how to approach it in a real ethical trial. And the ethical part is not requiring them to avoid a hysterectomy, but is there a way to allow the patient to have shared decision-making and choice, which is what we've been working on here. There was one more comment or question in the chat. If I can ask Dr. Rosenthal, any comments on the obesity paradox in cancer?
Can you explain me more about the obesity paradox? What do they mean by obesity paradox?
I think what they mean is that patients, some studies suggest that patients with a higher BMI had a decreased mortality risk, and that's quote unquote the obesity paradox. We kind of touched on this earlier when somebody said, can obesity be protective with cancer? And I think the general consensus is not really.
Yeah, as we mentioned before, while on the one side, being overweight can give you some cushion when you start losing weight and become catabolic due to chemotherapy. Being overweight will give you diabetes, hypertension, sleep apnea, and so many other, I would say, medical conditions that are not protective for you as a cancer patient, including what I was discussing before with Kunoor, the fact that the chemotherapy dosage is done based on weight. So the heavier you are, the more medication you're going to need, the more chemo you're going to need, the more detrimental it's going to be for your healthy organs. So I haven't read any literature that states that obesity is protective against cancer. It could be helpful if you have to go through a period of rapid weight loss due to chemoradiation therapy. But yeah, in the history of humankind, those who starve live the longest.
I think
So
also there's a global, if you look at the overview, right, you may be protecting against when you're getting chemo and losing weight, but overall, obesity is also, causative for dozens of types of cancer. So when you look at it globally, it's not a paradox. Obesity is not protective really in any way, shape, or form when it comes to disease processes. If it helps you, for a short amount of time while you're undergoing chemotherapy, I think that doesn't even pale in comparison to the protectiveness of bariatric surgery on all other disease processes. So overall, I don't really think it's very fair to say there's any protection with obesity.
agreed.
All right. Well, with that, yep, Shaina.
Yeah, I was gonna say, well, I think we really appreciate a lively discussion. I apologize for my tardiness for the first half of it, but thank you so much to Dr. Pena and to Dr. Rosenthal for a robust discussion with really good data. I screenshotted a lot, even though you didn't see me. So we look forward to the afternoon session, which will be happening this afternoon. And then this is our last fellow session for this academic year. And we look forward to starting again next month with our new fellows. And we'll go from there.
Thank you, Shaina. As always, to my partner in crime, she is a rock star. She currently has COVID and is choosing to isolate with us. So thank you so much. Dr. Rosenthal, pleasure as always. And we look forward to seeing you this afternoon.
Well, thank you everyone for joining for the afternoon sessions. We do appreciate Dr. Rosenthal and Dr. Pena. We're gonna give them a few minutes. I'm hoping the speakers will join us for Q&A. Otherwise, we'll wish everyone a good weekend.
So I think in the meantime, while we're waiting on them, it was really interesting. I was just watching the presentation and astounded by the numbers. I guess from time to time, people will publish on how things are going to be within the next 5-10 years, but I didn't realize so much of the population was going to be affected. My big question, which I'm hoping that they will log in, is, how do we as surgeons really get this information to the greater public? How do we get it to the insurance companies to actually get them on board with allowing us to provide medical services, surgical services to patients who actually need it to treat their obesity? Do you have any thoughts on that, Maher?
No, I agree with you. And I was actually wondering the same thing myself. And I'm thinking, like, with that kind of like data coming out now, are we going to see a change in some of those like screening requirement for colorectal, for breast cancer, for ovarian cancer? Are we going to start recommending maybe ultrasounds and colonoscopies for our patient population sooner than the recommended cutoffs for age, knowing that the incidence of those like hormonal cancers are higher? Same thing applies for like upper endoscopies for patients with obesity to rule out esophageal or gastric cancer or Barrett's. So obviously we don't have enough data to make those like recommendations yet, but I can see this coming. Those recommendations will have to change because, we do recognize now that our population is a high risk population compared to the general population. The other thing that I was very intrigued in hearing from Dr. Rosenthal, that difference between incidence and prevalence. So he made a very strong argument or point in terms of trying to differentiate between incidence and prevalence. And the same thing applies to the cause effect and the association. We truly don't understand at this point whether it's a cause-effect relationship or it's just association. And there's a huge difference between one and the other. And I think as scientists, as researchers, as surgeons and physicians, we need to try to find out what's causing cancer. Is it, and Dr. Rosenthal and Anna also talked about that. We don't truly understand if it's the lipids, it's the hemoglobin A1C, it's the glucose, is it the hypoxia? We don't truly understand what's causing cancer. And until we truly understand that relationship, we're not going to be able to know whether it's a cause-effect relationship or just an association.
Yeah, the other thing I thought was really interesting was that he was showing that it seemed like it's the % weight loss that is having, that's causing this effect, right? So, I mean, does it really matter whether patients are achieving this through diet and exercise or through medications or surgery? Is what we're doing as effective as we think? Yeah. I'm hoping so, but. I don't know how much time you wanted to give them.
Yeah, so we'll give them maybe another minute or so, and then we'll close the discussion.
In the meantime, if there's anyone in the audience who has questions, feel free to post them in the chat or in the Q&A.
Thank you, everyone. I mean, we truly enjoyed that talk by Dr. Rosenthal and Dr. Pena. Very interesting topic. More to come. Data is coming out. We're used to talk about obesity and diabetes, and now we're talking about saving lives by preventing cancer. So it's very interesting. I'm looking forward to more data on that subject. And again, thank you so much, Julie. Thank you for joining, and have a good weekend, everyone.
You too. Thanks.